Good afternoon, good morning, wherever you're calling from. My name is Faranjai. I'm the Deputy Executive Director for Speak Up Africa. We are a policy and advocacy action tank based in Dakar, Senegal. Immunization second of our webinar series, this time with a focus on the integration of immunization and other health services during the COVID-19 pandemic. Welcome to all of you. I'm pleased to see so many of you joined what promises to be an exciting conversation on the importance of immunization for reaching communities with essential primary health care services, including nutrition, malaria prevention, WASH services, and family planning. Today, we aim to highlight challenges and opportunities of implementing an integrated primary healthcare infrastructure on a policy and a programmatic level that national and global partners could consider. Hopefully, through this conversation, we will also provide a platform where partners can share lessons using respective expertise to work into a more integrated and efficient way to strengthen the delivery of essential health services and reach more missed communities. And finally, help move towards a more integrated approach between the different health programs as a way of reaching missed communities. By the end of this discussion, our ambition is to shed more light into how different countries are integrating immunization and other health essential services, how an integrated approach can increase coverage and reach missed communities with a full course of PHC interventions. To kickstart this conversation, we have a great and diverse panel of experts who will help us draw innovative solutions from country case studies. Let me start with Ms. Chika Ofor, who's the founder of the Vaccine Network for Disease Control, a Nigerian not-for-profit that focuses on immunization, maternal, child, and adolescent health. She believes that vaccines are one of the greatest innovations known to man, and she has intentionally empowered over 3,000 women to become vaccine advocates in their communities. She's a gender advisor, a health advocate, and a community development expert with significant operational experience within and outside the non-for-profit sector. Welcome, Ms. Ofor. We also have with us today Dr. Florence Simbumana, medical doctor with a passion for global health and social justice. Dr. Simbumana volunteers with the Rwanda Non-Communicable Disease Alliance and the Amazon Nutrition Cabinet, where she campaigned to prevent malnutrition and non-communicable diseases. She has worked with the Medical Students Association of Rwanda as an advocate and peer educator on sexual and reproductive health. Dr. Sibomana was also the vice coordinator for the Rwanda Village Community Promoters, working with underprivileged communities from rural areas. She's a committed gender equality advocate and Girl Guide. Welcome to you, Florence. We then also have Dr. David Kunchuk, who's the EPI Regional Coordinator at the African Field Epidemiology Network and Fellow at the Center for Epidemiological Modeling and Analysis. Dr. Kunjuk trained in medicine, public health, and epidemiology. He currently offers immunization technical assistance to the states and counties in South Sudan through mentorship, identifying public health problems, analyzing data, and making data-driven decisions for intervention. He is passionate about conducting research and motivated to continue growing in the field of public health epidemiology. Welcome to you, David. And last but not least, we have Dr. Ephraim Limongo, who's the Associate Director for Immunization at UNICEF. Dr. Limongo oversees the immunization and vaccines-related work of UNICEF, spanning across several countries and several regions, I should say, and over 130 countries. Prior to joining UNICEF, he served as the Regional Immunization and Primary Healthcare Focal Point at WHO Afro. Welcome, Ephraim. Thank you all for being here. Without further ado, because we do have a lot to cover and an exciting program ahead of us, we'll get started then with the discussion. Let me start with the last speaker I have introduced, Dr. Ephraim Limongo. Dr. Limongo, there has been great interest in integrating several health services within immunization programs. The response to COVID-19 offers an opportunity for a renewed approach to integration of primary health services to ensure greater efficiency and ensure that children are reached with the full comprehensive package of services needed to realize their good health. Immunization programs generally reach more children globally than any other health intervention, offering an effective delivery platform to integrate other health services. Could you outline for us how you think immunization services have acted as an entry point for essential primary healthcare services? Over to you.
Thank you very much, Farah. Thank you so much for the generous introduction. And happy to join this conversation with exciting topics and very interesting discussion points. I would like to wish everyone a happy World Immunization Week. Every day is a day to speak about immunization and vaccinating children, but this week is quite unique. So we invite everyone to be as vocal as possible to advocate about vaccinating children, and which would be a greater means to ensure long life for all. In UNICEF, immunization is one of our priority programs, and UNICEF has been providing immunization-related services and technical assistance to countries for the past 70+ years. We are by far one of the primary providers of immunization services to many low and middle-income countries. And today is a great opportunity to share that work, but I would shed much more lights on the principles and the hows of conducting integration. As Farah was saying, immunization is a very important program, given that it reaches a significant number of children. And it's one of the programs that has significantly higher coverage. And that gives it an opportunity and renders it as a very selected platform, which will be able to help us integrate other maternal and child health services with a clear intention that if there is a child that you are able to vaccinate and save from a vaccine preventable disease, but if that child succumbs to malnutrition and dies, there is no use of really putting immunization services alone if you are going to miss or lose that child for malnutrition, or if you're going to lose that child for diseases such as pneumonia and diarrhea. And if you can make sure the systems that we have at primary care level are optimized enough to be able to make sure they provide services necessary, that is human focused, children focused, without the need to verticalize immunization, nutrition, and disease prevention and treatment, that is a great opportunity that can really be leveraged. So the intention is saving mothers and children. And as we do that, integration comes as offering a great opportunity. Many people use integration to mean several things. Some people use it to refer to bundling of services, and some use it to refer to introducing a new program into an existing primary healthcare service or health service delivery program, so as a new package. And in some places, they refer it as an opportunity to really bring in even non-health services to be integrated and provided along with health services, including water and sanitation, nutrition screening activities, and even educational activities that can really be integrated within the system. I'll be very happy to share a slide, and I kindly request the host to share some of the slides that I would, yes. Thank you very much. So I'll start by covering how and why we will need to integrate services within primary healthcare, and particularly using immunization as an entry point. But I'll start with one example that UNICEF works in Nigeria. Next slide, please. So you can see in here a number graph that really shows you the impact of integrating services. And many of you may already know voluntary community mobilizers that operate within Nigeria to provide community-based interventions, particularly focused on prevention. We have tried an engagement whereby we use these volunteer community mobilizers who are heavily focused on immunization services to also use the platform to identify women who are pregnant and refer them for antenatal care. Unless and otherwise, these VCMs are encouraged and supported to be able to identify these pregnant women. There is a good likelihood many pregnant women who come with their kids to have their children vaccinated are likely to be missed. So encouraging these VCMs to be able to identify these pregnant women really enabled many women to attend more antenatal care services and also to also take vaccinations such as TT vaccinations. And also they've been able to be registered in the first trimester. So you see the numbers in orange in here that shows you the increase in access to service, because we used one entry point that was conventionally used for immunization to also add antenatal care services and identifying women who are pregnant. It gives you an idea that this can also be used for nutrition services. This can also be used for family planning, given both platforms bring children and mother onto the health facility, or also bring mothers and children to the frontline service. Next, please. So I was trying to imply integration means so many things, but there is a reason why we use immunization as an entry point to deliver primary healthcare services. But particularly the main thing is that it helps us to minimize missed opportunities. There are so many missed opportunities to your surprising service delivery, where you would see a mother and children come to a health facility, the child is vaccinated and nothing else is given. But when you have the opportunity to see the mother and children together, the mother and the child together, it means that you can provide nutrition services, which means you can screen the child for malnutrition, you can provide vitamin A, you can provide deworming services, and you can ask the mother if she has family planning needs, if she is also pregnant, and if she needs antenatal care, and if she has also other needs. But in many of the programs are somehow structured in a way to provide vertical services. So if a child comes for vaccination, then you'll find facilities only providing vaccination and let the mother and child go. So it is very important that we talk about integrating services and providing bundled services at health facility level, because it helps us to minimize missed opportunities. It is also a great opportunity to streamline services. And whenever you have a challenge of finding a child that missed a particular service, such as their second dose of vaccine or their third dose of vaccine, it helps to track also defaulters. And in any primary healthcare facility, you do not only give an immunization, but also other services. So it helps you to provide much more bundled, wider, and deep services. And at the end of the day, as I was trying to mention earlier, when you vaccinate a child, when you screen for malnutrition and treat them accordingly, and when you help the mother to seek services that are necessary, it helps you to improve outcomes of underserved communities, to improve outcomes of mothers and children. So it's heavily user-centered. Next, please. And if you're not giving the services in a bundled form, it means that parents will need to come back and forth to access each service, which would have significant out-of-pocket payment. So the key question would be, how do we do this integration or bundling of services at system and service level? Particularly at system level, it means in terms of program management, providing integrated services would require a shift from vertical disease-focused approach, which we focus on treating, for example, a particular disease such as malaria and only giving immunization, to a much more integrated fashion that centers, that focus on the child and the mother, and making sure all services are built across the continent. It will require us to optimize our critical resources, such as human resource, and would require us to build skills and also make sure our supply chain systems are strengthened, not only to provide vaccines, but also other life-saving commodities. And it will require our services to be developed and strengthened, capturing not only immunization activities, but also other child-focused interventions such as nutrition and treatment of sick child, and also reproductive and maternal health services. There are several platforms that we can do so. We can use health centers and health facilities to provide integrated services, but we can also use this campaign activities that we normally use to provide vaccines to also bundle additional services such as deworming and vitamin A for children. Next, please. Here is a little bit of commercial about UNICEF, what we did particular to integrating services. There is one critical example where we have been implementing solar-derived refrigerators have been the greater focus of our supply chain strengthening activity for the last several years, along with the Gavi Alliance. And later on, we have learned only having a solar refrigerator does not necessarily improve service availability, given that the facility would also need to have power to be able to provide other services for mothers and children. And now we are moving from a particular focus on using solar-derived refrigerators or putting solar panels for the functionality of refrigerators to much more larger solar panels to be used to also provide energy and power for the overall health facility. So we call it health facility solarization, so expanding the reach of these services. And previously, we have been working on strengthening cold chain capacity and supply chain systems, heavily focusing on vaccines. Now we are expanding that, given at the health facility level. If you go and look and open the refrigerator and see, you don't only find vaccines, but you would also find oxytocin, or you would also find other family planning commodities being kept within the refrigerator. So the need to make sure all these are accommodated in light of giving service for mothers and children have been found to be important. So we are expanding and using also innovative methods to reach more mothers and children. There has been so much work on waste management for vaccines, given the need to really safely dispose needles and syringes. But later on, we realized there is a need to really build capacity for waste management across the primary healthcare continuum. And that is now a greater focus of engagement at facility level in low and middle income countries. Next, please. Another level, which is a very important entry point, is the community level for integration, whereby community health workers are the great interlocutors. In some countries, you will find different typologies of community health workers. Some work on nutrition only, some work on immunization only, and some of them work on family planning or maternal and child health only. And this is because of the source of funding, that specific funding platforms support community health workers to be able to provide only one service. But the community health workers have found their way around to integrate services, because you will find different community health workers operating in different programs. So one community health worker doing family planning and at the same time doing nutrition and also immunization services. But it's important that we make sure our integration is heavily focused on community level, because at the end of the day, both it requires preventive activities and also the local community to be engaged to improve uptake of services. And it will give us the opportunity to address all health problems at a time and engage community gatekeepers such as religious leaders and influencers going forward in making sure services are accessed by mothers and children. So community level engagement is the critical entry point as we do integration. Next, please. Finally, at the end of the day, there is a need for integration to happen at an individual level by really considering the critical challenge of that individual, particularly the mother. Imagine in your mind a very low resource setting where a mother has so much opportunity cost, so much to lose for coming to the health facility, because there are so many things at play at the same time. When a mother decides to bring her child to a vaccination post, it means that she had to avoid or leave other household chores, which are not necessarily supported by any member of the family. She might have other responsibility, for example, the need to look after her sister's child or someone in the community. She may have other responsibilities of going to the market and buying things for her family. So whenever she decides to come to the facility, all these things are at play. And the decision to come to a facility is a very difficult decision, because it would also require additional costs for transport and other required services. So it's important that we design our services to be heavily human-centered by understanding the challenge and difficulties of that particular mother. And we'll need to be able to build a social listening mechanism whereby we understand the difficulties these mothers face and make sure our services are integrated so that the mother doesn't have to come again and again for every little service that she needs. And our demand generation interventions would also be a holistic ones when we do this human-centered design of our health service delivery in light of making sure uptake is quite high. Next, please. As we do all this, we have seen COVID-19 has significantly impacted our work in integrating services as part of its impact due to the disruptions that have been caused. And many of you are already aware of these numbers, whereby our recent estimate of vaccination coverage for childhood vaccines have shown a significant backsliding. And the recent coverage estimate showed a DPT3 coverage of 83%, which means we have went back almost a decade in terms of coverage. And this significantly shows that we have lost close to 23 million children who happen to be either under-vaccinated or unimmunized. And we have seen also an increase of unimmunized children, or as we call them, zero-dose children, by about 3 million plus, 3.5 million to be exact. Next, please. The same happened for measles, whereby both the first dose of measles and the second dose of measles have shown a decline in coverage as a result of disruptions caused by COVID-19 pandemic due to the restrictions of movement and the closure of facilities, particularly in the earlier days of the pandemic. And an additional 18.2 million children did not receive critical second dose of measles protection program, which is the MCV2. And so many campaigns have already been postponed, and new vaccine introductions that were planned in several other countries, including human papillomavirus vaccine, have also been postponed, which impacted immunization significantly. Next, please. So the main reason we're raising this is even immunization provides the platform for other primary healthcare services. A decrease in coverage of immunization means a decrease in reach to these particular communities. Going forward, as we do integration during and peri-COVID-19, there is so much talk about post-COVID-19, but I don't think there will be such a thing as post-COVID-19, given that the disease will be with us for the foreseeable future. But there are greater challenges that we have witnessed that COVID-19 has caused, but so much opportunities that can really be leveraged for integration of service. We have seen there has been significant overstretching of systems, which overwhelmed health workers. And economic slowdown, whereby governments had to divert resources from health towards non-health interventions. And there has been also decreased in service seeking by parents, because this economic slowdown has actually impacted household incomes. So parents had to choose between putting a food onto the table versus visiting health facilities. And the COVID-19 has really brought, it's a return of the vertical disease-focused approach, while so much has been talked about horizontal integration of our efforts. But great things emerged due to COVID-19, where we have seen governments truly step up against a particular public health threat, whereby they leverage the whole of government approach and mobilize domestic and global financing. And the global community has actually stepped up with a significant level as well. Several innovations emerged, including data and digitization. You can see from country to country systems that range between QR code-based identification of individuals to heavily biometric-based data systems, and new and modified service outlets that have really been also a lesson for immunization in many other services, including using mass vaccination sites, using religious facilities and churches and mosques for vaccination, which could also be leveraged for other services, and also extending the opening hours of health facilities to weekends and moonlighting. And many of such new approaches to service delivery can actually be used for other services. And so many legacy investments. We have invested so much in cold chain in UNICEF, for example, which we believe can also be used for strengthening immunization in other services. And we have also invested so much in demand generation and building additional assets, which could strengthen primary healthcare interventions. Next, please. So at the end of the day, we have an opportunity, and utilizing this opportunity is up to us. But integration, it all starts with a shift in mindset. Mindsets are the basics. And as we really work on mindsets of health workers, program managers, and supervisors to really integrate services, then we can leverage much of the potential. Over. Thank you so much. I really appreciate the opportunity to speak on this important platform.
Thank you so much, Ephraim, for setting the stage for us. You insisted on our common intention, which is to secure mothers and children. You've also clearly outlined how we can go about this integration and the systemic changes that would allow us to reach our objectives, including an increase of human resources, strengthen supply chain and logistics as well. I very much appreciated your focus on the human-centered design approach as well. So thank you so much for setting the stage for us. I understand you may have to leave before the end of our discussion, but if time allows, I would love to be able to come back to you with additional questions. But if not, thank you so much for being with us today. It's a pleasure to have you. Let's now hear from David, Dr. Kunjuk. As a reminder, Dr. Kunjuk is the EPI Regional Coordinator for the African Field Epidemiology Network. David, I hope you can still hear me.
Yes, I can hear you.
Brilliant. David, how has South Sudan integrated nutrition and immunization to deliver these services through PHC systems? Could you share with us some maybe some best practices and lessons learned from South Sudan?
Yeah, thank you so much for the introduction, and thank you for inviting me to this very important platform to discuss ways to increasing or to capturing more children for vaccination. So South Sudan is a country of many challenges. And before we realized in 2019 that at the nutrition side, we have this many children missed for immunization. And because of that, we decided that the way to go is integration. And for that, I would ask the hosts to share my slide, and then I will give a brief talk on integration. Yeah, thank you so much for sharing the screen. Yeah, this is in line with a policy brief by Gavi in 2019 on equity from birth and committing to integration. This is a case of South Sudan, and we looking for more ways and approaches to get more children who are missed at the OPD, who are missed at the OTP, the outpatient therapeutic program posts, who are missed even in the inpatient department. So with this, the government of South Sudan, with Gavi in 2019, scale up integration approach in all counties. First, specifically in the counties that were doing poorly when it comes to immunization. Those counties were identified to have many unimmunized children. And so we first started with those counties and then bit by bit scaling up to other counties. Next. Next, please. Yeah, so about South Sudan, we putting into consideration what immunization can do to preventing vaccine preventable diseases in terms of costs and in terms of geographical coverage. We're also looking at VPDs as one of the major causes of mortality in South Sudan, and we are saying integration can reduce mortality among children. So this is in line with SDGs, which focus on reduction of under 5 mortality, and by 2030, it should be reduced by 25 deaths per 1,000 live births. South Sudan is unlikely to achieve this target, this indicator, by 2030 because of the following. Next slide, please. Yeah, South Sudan has a fragile health system dating from a prolonged conflict, and thus our mortality has been constant since 2010. And so our partners, UNICEF, WHO, and others have been working hard bring down this under 5 mortality. And this is through provision of vaccines, ensuring that we have vaccines where they are needed by UNICEF, WHO contributing technical assistance, other partners implementing vaccination activities at the state level and the county levels. This is a requirement by Global Vaccine Action Plan that to capture more children for vaccination, we need to integrate. We need to get more children at the outpatients. We need to get more children from nutrition sites. We need to get more children from inpatient departments and many more areas that we have these missed children. So it's because with this, we are looking for the ways, and we are encouraging the immunization partners to integrate the services at the OPD, at the IMCI, and also encouraging the reward system. Next. So immunization agenda for 2030 also emphasizes on integration. In fact, this is one of the aspects of the immunization agenda 2030. So our country, South Sudan, has not been able to provide or meet the maternal services, maternal, newborn, and child health services, including immunization. So Gavi in 2019, with the Ministry of Health, came up with additional support. And this support was to strengthen immunization service by providing funds to tailor immunization services and nutrition services at the counties, right from the states and the counties to the health facility level. Next. We know that our immunization services have been implemented vertically, and we have single programs. If it is maternal child health, then they don't consider other services, primary healthcare services. Nutrition, just single-handedly. So what integration can do, what integration has contributed in South Sudan and can do is reducing mortality reduction. And we have found out that it is a very efficient model for sharing resources, and it is technically sound and also can promote equity in identifying these zero-dose children. So we have evidence, and we'll see in the next slides how we have been able to improve our Penta-3 coverage. So we have nutrition programs, and these nutrition programs are tailored at 858 sites. And we are reaching over 200 children under 5, supported by Gavi and other partners. And we have been deploying methodologies such as co-location of the services, co-delivery of the services, and co-reporting nutrition data and immunization data. Next. So we've been doing also screening at the nutrition sites, and we are talking of OPD, we are also talking of IPD. We're talking about screening these children between from birth to 23 months. We are targeting children who are zero-dose and also under-immunized. So with that, We do frequent orientation on job, and we also do supportive supervision. Supportive supervision checklist, we have integrated the checklists with also integration aspects, including the nutrition. And we do frequent review meetings to monitor how the integration is being implemented. We do follow up, and we do staff support. Next. So all this comes with collaborative decision making. We do this with dissemination of policies. I've mentioned that we have integrated this policy into REC approach policy integration. We have so that when you go out for supportive supervision, you look into these checklists, the aspect of integration and nutrition. And the approach is looking at the child health card at the nutrition post. Whoever comes to the nutrition post must be screened for vaccination status and referred to EPI unit before they get the services. Next slide. Yeah, so this is the model. This is a simple model that we have been trying to implement. And we are saying in South Sudan, we have community health, Boma Health Initiative. And this Boma Health Initiative as community mobilizers stationed at the community level, at the Boma level. The Boma is smallest administrative unit at the community level. And so these are the persons or the personnel that do screening at the health facility, at the community level. They do defaulter tracking and refer the children to the health facility for immunization. We also have another group, which is integrated community mobilizers network at the community level. They also do defaulter tracking and do referral to the health facilities. So we are leveraging on this community, on these strategies to have children coming to the EPI unit and get vaccinated. So these children are referred to the health facility, and we are having them at the OPD. So when we have them at the OPD, we do screening. And so we use EPI tools, and these EPI tools are such as child health card, where we screen for vaccination status. If the child is not vaccinated, the child has to get immunization services first before they come back for curative services. So and that's why we've been getting more children at OPD and even IPD. So we have also children coming directly to the nutrition side from the community. So we just don't leave these children to get the nutrition first. We first get them screened, refer them to the EPI unit, have them vaccinated, and get back to get their nutrition services. So these nutrition services are offered at the outposts. They stand alone therapeutic sites or at the health facility level. So it's easy to have these children, and we have realized that these children are many in the nutrition posts than in other departments. So we have been encouraging the implementing partners to do more at the nutrition posts. And I will discuss briefly later on how the implementing partners have been able to capture more children. And we are saying, let's pair funding. If we have funding, if you have funding for nutrition, let's also have funding for vaccination, so that we have co-delivery and I will talk about MedAir. MedAir, which has been delivering immunization services and nutrition services at some counties, specifically in northern part of South Sudan. And this county is called Awil Center. And Awil Center was a center that was a county that was doing poorly previously. But right now, as we speak, is a best performing county because of the core delivery of nutrition services and nutrition services and vaccination services. We're also looking at the outpatient, inpatient. Children who are admitted in the inpatient department do not get home without having screened for vaccination. So depends on the severity of the disease. So before they are discharged home, we have to ensure that these children are vaccinated, and then they are referred to EPI unit for that vaccination. We have sick child clinic. Sick child clinic do screening of these children before they are offered curative services. And we advise them if the child is, of course, severe, in severe condition, we offer curative services first. Then the next thing now is refer this child to EPI unit for vaccination. Then maternal health child clinic. And at maternal health child clinic, we are not only looking at children coming with their mothers, we are also looking at the mothers referred for vaccination, for TD vaccination at the EPI unit. Next. Yes, so this is the impact of immunization, of integration with nutrition services in South Sudan. This is the study that was done by Idris in 2021, interventional study, where they looked at the status before the intervention, status of penta-3 coverage before the intervention and after intervention. And the results are amazing. We realized that this improved penta-3 coverage, and you could see the results from your screen. First, the third dose. Look at the third dose for penta-3 in below 1 year children, from 32% to about 52%. That is amazing. So this is what integration can do: improving immunization services and reduction in dropout rates after integration. So we can also look at the dropout rates of this intervention after the intervention, and there is significant reduction of dropout. Next slide. I think this is the same slide. Next. Yes. So we're looking at the dropout rates of the immunization, and this is, we are talking about penta-1 and penta-3. So you're looking at what we're able to cover. Okay, sorry. So in the next 2 minutes, let's go to next slide. Yes, this is what I was talking about, a Will Center, which was being implemented by MedAir. We are seeing in year 2020, when they ended their project in a Will Center, we could see we had about 916 more children vaccinated than it was in 2015. So we had 1,116 unvaccinated children. But after the intervention, integrating the nutrition and immunization services, we're getting more children. And this counts to negative dropout. And we are seeing there has been also dropout, although the dropout has not been reducing. We are seeing we have unvaccinated children dropping. So also in Awilis, where this integration has been happening, we're also looking at the reduction of unvaccinated children to about 1,300 children. So this is the impact of integration in South Sudan. Next slide. So we've been having also challenges, as I've mentioned previously, that South Sudan is a country of many challenges because of the previous conflicts and all that. So we have vaccinators. We call them vaccinators in South Sudan because these are individuals which do not have basic professional training. And they are from 4 graduates, they are from 4 dropout. So we pick them and train them on job. So we lack polyvalent health workers to implement this integration. Because of inability to retain these workers, we keep losing them and go for other greener pastures. So we're also having training curriculum which have not been yet integrated. So we are looking at having nutrition training program integrated into immunization in practice. Guidelines. So that's the next thing we're going to is for. We have seen most of them are trained. So what are the? We also have challenges that connected to policies, and I've mentioned about pairing funding. So with all those challenges, we have had lessons, and these lessons we learn is that most of these integration activities is dependent on regular monitoring and motivation and health education. Children are vaccinated at the OPD are likely to return for subsequent doses because they come voluntarily. But those who are at the nutrition post might not come because they're interested in getting nutrition services. So mothers and caregivers value nutrition. And this is from the results of qualitative research that I did in one of the, they're only interested in nutrition. They don't care about vaccines, immunization services. So the thing that they don't think they will benefit from the immunization services. They only see immediate benefit from nutrition services. So we have seen decreased competition for resources and duplication of services at the service delivery point. Next. So in conclusion, we want to do more integration because this is the key driver of immunization services and reducing missed opportunities for vaccination, and also improving coverage that curbs vaccine preventable disease outbreaks, and hence reducing under 5 mortality. It is a key enabler for equity and a core element for universal health care. Next. Next, please. Yeah. So we want to scale up as our next step, and we want to incorporate policies that will encourage integration at the lower levels. So thank you so much for listening. I will be happy to address some questions. Back to you.
Thank you so much, David, for this brilliant presentation and for sharing such tangible experience and the model implemented in South Sudan as far as integrated nutrition and immunization services are concerned. You have insisted on collaborative decision-making, integrated reviews across levels of intervention, and the need to have clear policy guidelines. The impact of integration in your context is quite encouraging in terms of overall immunization coverage and the reduction of dropout rates following this integration, despite also many challenges relating to human resources and inadequate funding allocation. We have a few questions coming in the chat box, so I'm really hoping that we'll be able to get back to that and hear a lot more from you, David. Thank you. Now, if we can move to Chika 04, would love to hear from you about how you have used an integrated approach in Nigeria to include polio and routine immunization messaging with COVID-19 response activities. Again, just before you start, Chika, I would love to again encourage people to our audience here to have their questions in the chat box. We'll make sure to have a Q&A right after this, and we want to make it as engaging as possible. Over to you, Chika.
Hello, everyone. Can you hear me? I hope you can hear me.
Very well.
Okay, hello everyone, nice to be here. I'm really grateful I'm here. And I also want to say that in Nigeria, we had a National Vaccine Summit about 10 years ago. And this April is exactly 10 years that we had the National Vaccine Summit. There were some commitments. And now after 10 years, we looked at those commitments. We didn't even know we had gone far, but we can actually say that we did move a bit. So for us in Nigeria, the National Vaccine Summit moved us towards dovetailed into the AI Immunization Agenda 2030. So for African Vaccination Week, that's what we're going to be talking about. Thank you. So my slides, please. Hello, yes, integration of immunization sector, another essential services amidst COVID-19. The whole family approach is an incentive that isn't money. So now the whole world is talking about integration of services, everybody's talking about it. But the point is, how do you integrate these services? How do you make demand and supply meet at a point? I have worked in the immunization space for over 10 years, and we worked at the national where policies are developed. And then we also worked at the state level and then at the community level to see the implementation of these policies. And then many times they don't quite pan out as we expect, And then one day we got this whole family approach. We got a lecture about it in one of the states talking about the whole family approach. And immediately I had a light bulb moment. I said, this is it. It is simple. I'm an NGO. I love working in community. The demand and supply. The demand is the community is very important that you demand for these services, and it's very important that the supply of these services in the PHC are available. So that is it. So the COVID-19 pandemic exposed the fragility of the healthcare system and tested the acceptability of vaccines in Nigeria. And there's really need for innovative strategies and approaches to change the behavior and improve uptake of vaccines. The whole family approach is a strategy where every family member can access at least one health service during a family visit to the health facility. The health facility becomes a one-stop shop, a one-stop facility where childhood vaccination, that is routine immunization, polio vaccines, screening for hypertension, screening for diabetes, HPV vaccines, in one visit. Before, you can go to a facility and say, okay, today is not, we're not giving pentavalent vaccine today until next week. We can't open this vaccine, But now, an approach where every member of the family can go to the PHC and get that one service and get at least one service in that one visit, which means cut costs, it can be planned, it becomes like a family outing. Daddy, mommy, teenage child, grandma, everybody You know, can you just visualize that approach where you can actually dress up, you and your family, your husband, and then you get to the facility while mommy is checking herself for reproductive things, the daddy is checking his sugar level, the baby is taking routine immunization, you know, and taking the polio drops, and then the teenager is taking the HPV vaccine, and everybody finishes and comes home looking happy and then you can plan for the next visits. That is what is practicable. That is what is good, because first and foremost, it cuts costs. Secondly, it makes you plan properly. Thirdly, if the primary healthcare center, if the services in the primary healthcare center, they are cautious staff, they are warm, they tell you what is happening, you will find that going to the facility becomes joyful, happy. That is where we come in, because we are NGOs, we simplify things. Next slide, please. Next slide. In front of me is Husseina, in front of me is Mohammed, my community volunteer. At the time we started working in his community, the Mangaza community, he had about 8 or 9 children. So we wanted him to, you know, start family planning. And he did. Unfortunately, the wife had a challenge with the family planning device. And then they had to take out that particular device and wait for her so that she can get ready to take the second device. That waiting period, she got pregnant. Within that waiting period, I was very angry with Mohammed. You have 2 wives. Why allow Amina to get pregnant? Or you have too many children. And because of that, I didn't talk to him for a very long time. And that is one of my adopted communities. I also believe in adopting communities and adopting facilities. And then before we knew it, it was 9 months and she was about to give birth. I called, I said, Mohammed, what's happening? Has Alisa given birth? She said, no, he go health center. And when she reached the health center, they say something is wrong with the baby, that we have to go to hospital. And back with I don't have money. And then he sent her back home. She was in labor for 48 hours. 48 hours, not knowing what to do. I had to quickly come in, take her to the tertiary institution. The doctor was even convinced that the baby was dead already. And then fortunately, the baby did not die. And they gave birth to this beautiful baby that she's holding here in front of us, called Omar Chika Mohammed. They named the baby after me. Why am I saying this? At that time, this was about maybe 4 years ago, the integrated approach had not even started. So, and because of that, Mohammed never went to the health center with the wife, and she hardly even went to the health center. It was when there was a challenge that he went to the health center, because they did not trust the health facility. The health facility did not have the integrated services. If you wanted to go to the health facility, you had to travel a long distance, and not only travel a very, very long distance. When you get there, you may not just get that service that you're looking for. And that is why we almost lost Alisa. But with the whole family approach, it wouldn't have happened. Because first and foremost, she would have been going to Mohammed would have encouraged her to go to the PHC, because he too, he's diabetic, by the way. He too would have gone to check, would have been able to check his sugar level, do 1 or 2 services with her. It would have been like a family outing. They would have been prepared for whatever eventuality. And the whole family approach also talked about a 2-way referral, where if there was something the health center could not do, they would refer to the tertiary institution as an emergency, and you don't necessarily have to pay. So before we knew it, her life was saved. But that's not the story for Mohammed. Because he could never go to the health facility, he never had money to go to the health facility. If he needed to check his sugar, he had to go to the chemist. We did buy him strips sometimes to check, but for how long? The strips are not cheap. And because of that, one day he had diabetic coma. We had to cut off one leg. Then we cut off the toes first, then the leg, and then it affected his organs. And today, Mohammed is history. A very intelligent man. But if we had the whole family approach, the story would have been different. First and foremost, he would have been afraid of going to the health facility. He would have registered in the whole family approach. he would have known that it was possible for him to access care. And then when he gets to the primary PHC, he would know that the sugar would have been tested. His wife would have checked for reproductive health services. The children would have done polio. They would have taken their polio vaccine. The babies, the teenagers would have done all the necessary things. And if there was need for referral, it would have been easy for him to refer, for him to be referred to anyway. It is such a seamless, beautiful, simple approach that if that had happened, Mohammed would have been alive today. My heart broke. It was at that point I said to myself, there are so many strategies that were developed in the past with the states, with the national, about, outbreak response. We go to communities, we do this, we do that. Somehow these things never seem to be sustained. Somehow we never quite got there. But with this whole family approach, he just ticked that box. Because I have another example. In one of the facilities that we have adopted, we go there regularly to clean the facility, check out what is happening. If there's any broken chair, we help them repair. And I also advise, please adopt a facility, even if it means you just go there and sweep the facility. It works. And then when I got there, it was during the outbreak response, OBR. We saw a cute family. They came in, the man, the wife, and his little baby and the little girl. They came into the facility. As they got into the facility, the woman immediately went in for reproductive services. The little baby went in for polio services and other routine immunization services. Then the other girl was going for another service to check, malaria and all that. And then the man wanted to drop his wife and go away. And then they called him and said, "Excuse me, sir, please come, sir. Can you come and take a COVID-19 vaccine?" I said, "No, I don't want to take COVID-19 vaccine. That vaccine that they don't even know what is happening to the vaccine. The vaccine, they don't even check people's BP. They don't check sugar level to see whether you have the capacity to be able to absorb the vaccine, blah, blah, blah." And then the person said, "No, you can actually check your BP. You can actually check your sugar level and you will not pay." The man said, "Are you sure?" And he said, "Yes." And immediately he came. He checked his sugar level. He checked his BP. Everything was all right. He took the COVID-19 vaccine. As he was rounding up, his wife was rounding up. The man laughed and he said, "Wow, this is an incentive that isn't money." The whole family approach is an incentive that isn't money. He was so happy. He said, "Oh, you are serious now. Oh, so that means I can take that anytime I come. I can come with my family. I can come with them wherever we can plan to come." That is what the whole family approach does for you. And then I saw it and I said, my God, we have lost so many people. And yet, now the solution comes. How wish the solution had come before Mohammed died. Mohammed would have been on this Zoom call to tell you how you enjoy the whole family approach. But it's not to be. It's not to be. Next slide, please. My twin girls, Usaina and Hassana, the same story. One of the communities had to reach communities, Fulani community, they refused to take vaccines. We went there, advocacy, sensitization with the states, FCT, they joined us, blah, blah, blah. And eventually the chief, the Mengwa of the community accepted, and that, but we had to be the ones to take the children to the facility or else the children will not go. And I said, yes, I will do it, because I knew that if the Mengwa gets sick, that is the chief, you've gotten the whole community. And then we took these twin girls and they finished their whole routine immunization. After finishing, that was like 5 years ago. At the age of 5, we got a call and they said one of them, Husseina, had died. What happened? And Hassana was critically ill, that we should come. We took her to the hospital. After 4 operations, she died from pneumonia, a vaccine preventable disease. I was heartbroken because the primary healthcare center at that time did not have lights. They didn't have power. So whenever they needed to do vaccination, they had to go to the other PhD and bring the things for us. After that, they take it back, which meant that it wasn't a sustainable approach. And because of that, the people in the community did not trust the PhD at the time. Things have changed now, though. And then, because they now started going to chemists, I didn't know. They were going to chemists and the chemists were giving them drugs without diagnosis. And then by the time they realized that it was all wrong, it was late. We took Hassana to the hospital, 4 operations, and both girls, Husseina and Hassana, the girls that I myself took for immunization, died. They are history today. But I can tell you one thing, the whole family approach makes it possible for this not to happen again. But it needs the community, the family, and it also needs the PHC to be functioning properly. So it's like a husband and wife scenario. The demand, the supply, the wife is the community and the people in the community. The supply is when you supply the necessary, the PHC. And at the end of it all, it's like a husband and wife relationship. For the whole family approach to work, the primary healthcare center has to be functional. It has to have the necessary human resource. It has to have courteous human resource, not just necessary, courteous human resource. Their capacities have to be built to understand that sometimes the main reason people go to the primary healthcare center is because they trust the people that are there. So, if we want this to work, create demand in the community, we'll create that demand, build the capacities of CSOs to adopt this approach and make it vibrant, create demand, talk about, sensitize, be passionate about it, because it will work. These simple things are the things that work. And then the primary healthcare center has to be ready. Don't say that when they get there, sorry, today we're not doing Penta, come tomorrow. Sorry, we are not doing this, come tomorrow. We cannot open the BCG, we don't have up to 10 people. We don't want that. The primary healthcare center is a one-stop shop. Families have to plan, communities can plan to take a day and go there. And in that day, everything they need to do, they will do it. And if it's something that is beyond the capacity of the primary healthcare center, they can be referred easily. But this thing has to go through process, talking about the process, registration and all that. So what I'm saying now is, it is indeed an incentive that isn't money. I've seen both sides of the coin. I have worked with national, I have worked with state, I have worked with communities. I love community work, by the way. We have adopted communities, we have adopted facilities, we have adopted children. We see what I've been 10 years in this space. I can categorically tell you that this is an incentive that will work. Next slide. I know that I'm not even using my slide, I'm freestyling.
Please go ahead, Chika.
So the whole family approach presents a strategy of integration between EPI and COVID-19 vaccines, in addition to other health needs of the family. Can you imagine the fact that in a community, you want to now go to a facility, your husband is in agreement with you? Because many times, the challenges we have in communities is that the man is not in agreement. So he doesn't give you money for transport. If he doesn't give you money for transport, then you can't go. But when the man is in alignment, because he too has something he's going to gain, then indeed, going to the primary healthcare center becomes like a family outing. It becomes like a family outing. I know, because we have been part of the crew that have taken people there. Next slide, please. And this is one of the best ways to all the missed opportunities. You will get them back. Because once the experience in the PHC is a good experience, the news will spread like wildfire. Everybody wants to go and access that thing. When you know that if you go to the chemist, for instance, and you want to check your sugar level, you pay 100 naira for that. If you want to check your BP, you pay 15 naira. And then you are not going to go to the PHC, and you don't have to pay for these extra services. It will make it easy, because everybody has something to gain. So using the polio transition guide, Nigeria has defined 3 priority areas of focusing investment in polio resources. Routine immunization is one. And there are many, many missed opportunities. Word of mouth. We have learned that diarrhea of the mouth is when people say their experience and enlarge it. But however, when it's a good thing, they will also expand it. We have gone to we have adopted 2 or 3 facilities now on this. And not only that, because we know that the PHC cannot function properly, the whole family approach cannot function properly if the PHC is not prepared. If they don't have the facility, they don't have the human resource, they don't have the things that we need. So we are also going further, to have what we call private sector inclusion and citizens inclusion, which we are doing presently with the states and private sector, critical private sector people, micro private sector, macro private sector, to say what? Let us support the government to make sure that the primary healthcare centers are ready. So if what I can do is to visit the PHC and even just sweep or maybe just provide the BP machine, which is like maybe $10 or $15 now, that is one thing you can do. So we come in as a group and everybody decides to do one thing or the other. And then when you have done it, one person does not need to adopt a facility. 10 people can adopt a facility. It becomes your own. And once in 3 months or you go and check and see what is happening there. That is what we are doing. Private sector engagement to make sure that the whole family approach works and improve health-seeking behavior in order to improve universal health coverage. So we have a lot of things. It is not Uhuru, it is my passion. I know it will work. Next slide, please. But I know that it has its challenges as well. We need human resource, we need infrastructure, we need power. The state is ready, but they don't have the funds. So private sector, as we speak, we're working on it. And I'm going to work on it to the best of my ability with the private sector group that we have started with. And guess what? They're all women organizations, or an unrepentant woman. And I believe I wanted it to succeed. So I took the critical people that will make it succeed for me. And those are people, private sector individuals who own schools, some of them own restaurants, and women who I know are passionate about universal health coverage. Next slide, please. The challenges. Oh, thank you. So what I'm saying is that join me. I tell you, adopt a facility or adopt a community. Join us, let's make this thing work. And I tell you, it is an incentive that isn't money. Thank you.
Thank you so much, Chika, for that passion. Thank you for sharing your whole family approach, a one-stop shop for the entire family. Thank you for highlighting the human impact of integration, if only it could be scaled up. Thank you for reminding us as well as, as to what is at stake here, the very lives of entire families. So we do have a lot of questions in the Q&A, and I know we still have one presenter to go, but would love to be able to get back to you with a few follow-up questions as well. Brilliant, thank you so much. And I understand some of you as well are having trouble reading the slides, so we'll make sure to share those with the group after the webinar. So without further ado, our third and last speaker, Florence, I hope you can hear me if you're still with us.
Yes, I can hear you very well.
Brilliant. Hi, Florence. Can you share with us how you've used an integrated approach in Rwanda to strengthen routine immunization and nutrition services? Over to you.
Thank you so much. I'm Florence, as the moderator introduced me, and it's an honor and a privilege to be part of this panel sharing the experience used by my country, Rwanda, strategies and approach to ensure integration of routine immunization and other essential services amidst COVID-19. First of all, in Rwanda, we have that high level of political will, which is responsive and supportive to all health programs that promote human capital. This has been helping a lot, both for civil society organizations, for the government, and other partners when it comes to health programs. The second is a health system structure, which starts from community healthcare workers. In Rwanda, our community healthcare workers are polyvalent healthcare workers. This helps those community healthcare workers work on different aspects of health, where today they receive regular and continuous trainings, and they help in both community education, community mobilization, when they come to immunization, nutrition, breastfeeding, family planning, and some of them, they are at the level now to treat some condition in under 5 years children, where they may treat malaria, pneumonia, and they know when to refer those complicated cases to the next level of health facility, which is health centers. So we are having health centers in the press. Those health centers is the level of primary healthcare in Rwanda, where all preventive healthcare services are available and they are delivered. When I mean primarily preventive healthcare service, I mean routine immunization, nutritional services, family planning, and management of all those medical conditions. And they know when to refer, especially they refer those complicated cases to the district hospital. This health center, they are really located in the community where the population are able to access the health center. They are able to access health services closely to their home places. This is another second approach which may increase the coverage of the primary healthcare services where immunization is part of it. We are having a post called community environmental health officers who are at each health facility, I mean health centers, and they are those ones that are responsible for community healthcare workers. They are there to support community healthcare workers platform. They are there to help in training process of community healthcare workers to make sure that they are equipped with knowledge, but also they are adhered to their responsibilities, which help in accountability and proper follow-up of the work of community healthcare workers. Fourth, we are having community-based health insurance, which is one of the approach of risk pooling, where families in Rwanda, they contribute according to their socioeconomic category. The poorest families, they are covered by the government. This community health-based insurance, so far in the recent report in April 2021, it was having a coverage of 85.6%. in total population of Rwanda, and it helps all population to access healthcare services at lowest price and to remove the financial burden, especially when it comes to the need of healthcare services. The fifth is multi-level engagement, where in Rwanda, we have what we call social cluster ministries, but specifically Ministry of Health and Ministry of Local Government, they work closely on the important goal of human capital. Ministry of Local Government in this aspect of routine immunization and central services, what they do is more with community mobilization, but also helping families when it comes to setting targets of what families should achieve when it comes to development plan. And here, Ministry of Health, they are accountable to make sure resources and other needed services are in place to make sure the population can access health programs. So this approach of working together for both Ministry of Health and Ministry of Local Government, it helps to make sure that the community are engaged in planning of the program, but also in implementation of the programs. The final one, it's health information system, health management information system, which we call HMIS. This is a system that is based on each health facility, and it helps in reporting, but also in data management, where we have a responsible person called data manager. He or she is the one to report all information related to all services delivered at the health center to the central level, whether if it's a partner or a government, they are able to monitor and evaluate the success of each program that is entered in HMIS or Health Management Information System when they want to. So it really helps in reporting and accountability of different services, which I think it gives a good outcomes that I will mention below. But now I want to highlight some of the challenges. Despite all those strategies that were in place, there were some challenges on routine immunization and other essential services during COVID-19. The first challenge is it was fear of the population to go to the health facility because they were having limited knowledge on COVID-19 before, and everyone was worried like to get contaminated by COVID-19. This has limited a number of mothers to attend vaccination programs and other important programs like family planning and other healthcare services. But one of the important resolution the government put in place is to ensure that the government have responded on COVID-19 quickly with strong preventive measures, where we were having a task force responsible for COVID-19, the platform of community healthcare workers I mentioned earlier before, they were really helpful when it comes to contact tracing of COVID-19 population. They also played a part in home-based care during COVID-19 management cases. So here the challenges were resolved because of strong measures that were in place, including the establishment of different treatment centers, having enough workforce trained on the management of COVID-19 health workforce, but also having the using facial masks like being obligation to each population, social distancing, some necessary lockdowns. So this has helped the people to make sure like they are not really worried of getting COVID-19 when they went to the health facility, because they were sure that we are having different prevention measures in the place, and we are also having the treatment center that can help when it's necessary. And they were able to get updated information daily, especially on the status of COVID-19 in the country. So the good outcome that we had on those integration of routine immunizations and other essential services, it's having 96% of children under 5 who received all basic vaccination in 2020, because in 2000 we were having only 76%, but in 2020 we were able to have 96%. It's because all those approaches that I mentioned above that helped to lead this number of increase in about 20%. The second record is having 40% of Rwandan population who were vaccinated fully by 2 doses against COVID-19 by end of 2021. We all know that the pandemic was not planned, but because of those approaches and strategies that are in place, it has even helped in management, but also in controlling COVID-19, where vaccination is also a concern. And that was the result by the end of 2021. So I can't forget to mention my role as a youth leader for nutrition, especially when it comes to integrating adolescent health and nutrition in existing programs, where I was able to work with the district, and we were able to select one district champion for adolescent health, because it was an important element left behind in nutrition agenda. And currently we are having those district youth champion, where they are able to join the existing district committee, health committee, when it comes to discussing different health related issues. They are there sitting in decision-making body, where they're able to contribute in terms of nutrition, sexual reproductive health, but other related issues that impact adolescent health. That was one of the success we heard when it comes to using the existing platform and advocacy for adolescent nutrition, especially for me as a young leader for nutrition. And we are aiming to do more, especially when it comes to adolescent health, nutrition, education, and advocacy by using the existing platform. As it was mentioned by the first presenter from UNICEF, that integration is very important. It helps in the setting with limited resources, especially human resources, but also it helps in achieving the target, and it's not a burden even for the population to access all those services when they are together. Thank you so much, and this was a great opportunity. I'll be happy to respond to some questions when they are there. Thank you.
Thank you so much, Florence, for sharing these tangible examples as well with us. Unfortunately, we are running out of time, but most of the questions are now in the Q&A and the chat box I can see. So thank you so much to our speakers for answering those questions directly. That would definitely allow us to maximize each and everyone's time. Before we wrap up, I just again want to thank all of our experts and panelists this afternoon for this enriching discussion. We have insisted on the fact that to guarantee successful integration of several health services, a properly working health system is required with the required equipment and resources and supplies as well. We insisted on the need to create a shift of mindset. Effective integration is possible only if and when countries invest in building foundational capacities at primary care level to ensure basic services are indeed provided. We also mentioned the importance of trust, community ownership of the approach, as well as the need to prepare our health systems for these innovative solutions. And here again, I'd like to salute the need for cooperation between civil society and all of other national and subnational actors that are working in this area. Only by working together to create this integrated system, that leverages complementary strength of public health and primary care, will our health system truly achieve the capacity to deliver superior services to the benefit of our communities. So again, join me in thanking our dear speakers who've definitely showed their dedication, commitment, and passion, in the last 90 minutes. And thank you for all the participants who have joined us. We have over 100 people with us today. So thank you for making time and sharing your afternoon, morning with us today. Thank you again to the host for organizing these webinar series. See you all on Monday 12, where we'll have the third and last webinar of the series that will focus on immunization, financing, and accountability. Take care, everyone. Stay blessed.